Okay, let's go now to the second segment of the lecture, which is now the part 2, which is plain film interpretation. When you are interpreting a chest x-ray, you should follow the systemic approach. First is the overview and overall glance of the film. Check if it is a good inspiratory film and if the exposure is normal. Check the cardiac position and situs, followed by the cardiac size, the chamber enlargement, the great vessels, the lungs, and the ancillary findings. Okay, so you overview or the overall glance of the film, you have to ask yourself whether it is adequate or optimal for cardiac evaluation. Now, if you think that it's not optimal for cardiac evaluation, then you advise your rad technician to repeat the chest x-ray. Then, things to consider. First is your IEP, which is your inspiration, whether it's a good inspiratory film, whether the exposure is good, and also the position. Things to consider. Always remember that the chest x-ray is taken on full inspiration. So in other words, it is acquired in the inspiratory phase of the respiratory cycle. So the radiographer asks the patient to breathe in and hold your breath. And always remember that the patients who are short of breath or those who are unable to follow the instruction may find this difficult. Then, you have now your Now, the best way to determine the degree of inspiration is to start at the top of the patient's rib cage with rib number 1 and count down to the 10th or the 11th rib posteriorly. A general rule for average adult patients is to show a minimum of 10 ribs on a good PA radiograph. Now, always remember that older patients have less inhalation capability with a resulting low lung volume, which requires higher central ray location. Then, for the exposure, you have certain things to consider. Okay? On the left side, extreme left of the 3 slides, you have underpost chest x-ray, underexposed chest x-ray. Underexposed may simulate the appearance of a pulmonary congestion. Okay. Then an overexposed may simulate a diminished pulmonary blood flow on the extreme right. So, the middle x-ray film is a normal exposure. Then, next to consider is the position. Slight degrees of rotation or obliquity will substantially affect the cardiac contour and may alter the apparent size as well. Okay, now, on the extreme left, you have the levocardia, wherein the heart is predominantly on the left chest and the cardiac apex points leftward. While a dextrocardic patient or dextrocardia, the heart is predominantly on the right chest and the cardiac apex points rightward. Then you have the mesocardia, wherein the heart is positioned in the midline and the cardiac apex points directly inferiorly. Then the fourth is your dextroposition or the dextrovert heart, wherein the apex points leftwards, but the heart is located predominantly on the right chest, typically due to intrinsic forces like your atelectasis and your pneumothorax. Then cardiac situs. Okay, viscerous atrial situs. The situs refers to the pattern of anatomic arrangement, and the atrial situs is usually concordant with the organs on the visceral area. Hence, these two are described together. Okay, when you say cytosolitus, the morphologic right atrium is to the right of the morphologic left atrium, And the gastric bubble is on the left side and the liver is on the right. While the situs inversus is the morphologic right atrium is to the left the morphologic left atrium, and the gastric bubble is on the right side and the liver is on the left side. Okay? Take note of these two drawings. You have the normal organ placement wherein the right atrium in the thoracic cavity is in the same position as your organ on the right side of the abdominal cavity, which is the liver, while the left atrium is in the same position as your stomach, wherein you will see the gastric bubble, okay, on the left side of the abdominal cavity. In patients with situs inversus, the left atrium, okay, is now placed below is your gastric bubble because of the stomach. While on the other hand, the right atrium, which on the other side is, and below it is your liver. Okay, now you have what you call the situs ambiguus. This term is used when the identification of the visceroatrial situs is not possible due to paucity of anatomic markers. Take note that you have the liver, which is seen on both sides, okay? And take note that the heart is mesocardic. Okay, now this is just an exercise. This is a typical example of dextrocardia, wherein majority of the heart is on the right side, the apex is on the right, but the position of the liver and the gastric bubble is in normal position. Here in the next slide, you have a dextrocardic heart plus the liver is on the left and the gastric shadow is on the right. So you have a situs inversus. Okay, then you have a situs ambiguous heart. The heart is mesocardic and you have a bilobe liver. Now, the next thing that you have to determine is the cardiothoracic ratio. When you say cardiothoracic ratio, it's the ratio of the transverse diameter of the heart to the internal diameter at widest point just above the diaphragm. So how do you do this? Okay. You divide the widest transverse diameter of the heart by the widest transverse diameter of the thorax and the inner side of the rib cage. Now, how do you do this? Draw an imaginary line in the middle, then measure the widest diameter on the right and measure the widest diameter on the left, which is labeled as 1 and 2. Then you add that, then divide by the widest internal thoracic diameter at the level of the diaphragm. Okay? What do I mean by internal thoracic diameter? So, your line is in the inner side of your skin on the right, going to the inner side of your skin in the thoracic cavity. Now, a normal city ratio in adults is 0.5 or less, and the normal city ratio in the newborn is 0.65. In older children, the normal city ratio is 0.60. Okay, now, it's very important that you also have to evaluate whether there is chamber enlargement. So we start with the right atrial enlargement, wherein there is a lateral bulging of the right heart border, okay, and elongation of the right heart border. Length of the right heart border exceeds 50% of the mediastinal cardiovascular shadow. Another is you draw an imaginary line in the right midclavicular line if the shadow of the right atrium hits the imaginary line on right midclavicular line, then you label it as a right atrial enlargement. Okay, what are the disease entities that can cause a right atrial enlargement? So, the moderate to large atrial septal defect, wherein there is a interatrial defect, which is usually moderate size to large, wherein what this causes now are left to right shunting. Always remember that the pressure in the left atrium is usually higher than the right atrium, so there is abnormal flow of blood from the left side, left atrium to the right atrium. Okay? Then you have your Epstein anomaly, wherein there is downward displacement of your tricuspid valve into the right ventricle, wherein a portion of the right ventricle becomes a part of your right atrium. We call it the atrialized right ventricle. Then also moderate to severe tricuspid regurgitation, wherein there is poor coaptation of your tricuspid valve during systole. So instead of the blood that is pumped by the right ventricle into the pulmonary artery, because of the poor coaptation of tricuspid valve, a great amount goes into the right atrium. Then also there is what you call your moderate tricuspid stenosis, wherein there is what you call the coaptation of your tricuspid valve. Hence, during the diastolic phase, the tricuspid valve doesn't open fully well. Hence, there is pooling of blood into the right atrium, causing volume overload and causing pressure overload. Then you have your atrial fibrillation, your core pulmonary or the right-sided heart failure, also your pulmonary hypertension, moderate to severe, wherein the PA pressure is approximately 60 to 100 millimeters mercury. And also your dilated cardiomyopathy can also cause your right atrial enlargement. Okay, this slide shows you the box-shaped heart, typical of your Epstein anomaly. Take note of the large right atrium and also the afflicted apex of the heart. Then, the next slide shows you the preoperative chest X-ray demonstrating the enlarged upper mediastinum, aberrant position of your hyperplastic thymus, the thymic sale sign, which is typical in patients in the newborn up to the 3rd month. Yan. The next slide shows you the thymic sale sign. Then let's go now to the right ventricle, wherein on PA view there is rounding and the flipping of the cardiac apex. Always remember that below the right ventricle is your diaphragm, and below the diaphragm is your liver. So in instances wherein there's a right ventricular enlargement due to some pathological abnormalities or increased pressure or volume overload in the right ventricle cannot push down because of the presence of the liver. Hence, what happens is that the apex is uplifted and rounded. Now, on the lateral view, there is what you call the retrosternal fullness, wherein there is contact of the anterior cardiac border greater than 1/3 of the sternal length. So there is now what you call fullness at the back of the sternum, your retrosternal fullness. So you don't see much of your retrosternal space. Okay, now, this slide shows you on the extreme left is a normal right ventricle on lateral view. But take note on the extreme right, there is what you call retrosternal fullness, wherein you don't see the retrosternal space, hence you have a right ventricular enlargement. Now, what are the conditions that can cause right ventricular hypertrophy? First is your pulmonary hypertension. If you have a high pressure, there's difficulty of your right ventricle to pump blood into the lungs. Okay? Then you have your tetralogy of Fallot. As a review, you have 4. What are the conditions that can cause right ventricular hypertrophy? First is your pulmonary hypertension. If you have a high pressure, there's difficulty of your right ventricle to pump blood into the lungs. Okay? Then you have your tetralogy of Fallot. As a review, you have 4 anatomic defects in your tetralogy of Fallot. You have your large VSD. You have your overriding of the aorta, and you have your right ventricular enlargement plus your pulmonary stenosis. that pulmonary stenosis, because of the right ventricular outflow tract obstruction of the pulmonary stenosis, which is usually moderate to severe, what happens now is the right ventricle is pumping against the fixed ventricle, hence there is RVH. And also, during systole, there is direct streaming of the oxygenated blood into the aorta, which is usually overriding the VSD. So there is direct streaming of the oxygenated blood into the systemic circulation. Also, your moderate to severe pulmonary valve stenosis can also lead to right ventricular hypertrophy, moderate to severe pulmonary regurgitation, a large VSD wherein there is equalization of the left ventricular pressure as well as your right ventricular pressure. Now, severe mitral stenosis, what happens? Always remember, if your mitral valve doesn't fully open well during diastole, what happens is that there is pooling of blood into the left atrium. So there is a volume overload in the left atrium, and there is as well as your left increase in your left atrial pressure. Now, always remember that the pulmonary veins, which is usually draining into the left atrium, is valveless. So whatever pressure that is formed in your left atrium is reflected into your lungs. And always remember, the main pulmonary artery, which is connected to your lungs, okay, and whatever pressure is developed in the lungs is also reflected into your right ventricle. Hence, there is also what you call a right ventricular enlargement. So, in severe to moderate mitral stenosis, there is not only enlargement of the right ventricle, but as well as your left atrium. Okay, then you have your athletic heart, wherein because of the strenuous activities that is being performed by an athlete, for example, a triathlon athlete, there's a tendency for the right ventricular muscles to thicken. Hence, you have your athletic heart. Then you have your total anomalous pulmonary venous drainage, wherein the four pulmonary veins, instead of draining to the left atrium, is connected to a common pulmonary vein, and that common pulmonary vein is connected either to the inferior vena cava, to the right atrium, and to the right ventricle, causing now your, to the inferior vena cava, causing now your increased volume into the right ventricle. Now, let's go now to your left atrium. Left atrial enlargement, there is what you call the visualization of the enlarged left atrium. The first is your double density sign. When the right side of the left atrium pushes into the adjacent lung, this becomes visible superimposed or over beyond the normal right heart border, known as your atrial scape. Also, there is what you call also the oblique measurement greater than 7 centimeters. This is measured from the midpoint of the left main bronchus to the right border of the left atrium. So, this requires a double density sign, of course. Though this is thought to be the most reliable sign on chest radiography. Then, the third mogul sign can be seen on the frontal chest radiograph in the presence of the left atrial enlargement. It refers to the extramogul or bump along the left, the upper left cardiac cingulate just below the left main bronchus. The third mogul sign commonly represents an enlarged left atrial appendage, particularly in patients with rheumatic heart disease, specifically mitral stenosis or mitral regurgitation. Other causes that may also appear in the third mogul on the cardiomediastinal contour includes, okay, then you have your left atrial enlargement. In the mitral valve disease, there is enlarged left atrial appendage that bulges on the left side of the heart, seen by the large white arrow. Then you have the walking man sign, which is seen on the lateral chest radiograph, okay, and is a sign of the left atrial enlargement, it results from posterior displacement of the left main bronchus such as that it no longer overlaps the right bronchus. The left and right bronchus thus appear to be as an inverted V, thus mimicking the legs of a walking man. Let's go now again to the summary. You have your left atrial is simplified by your left atrial appendage, enlargement, double density, enlargement of the left atrial appendage, and the flipment of the left main stem bronchus, and the widening of the coronal angle. Okay, this is an example of your left atrial enlargement, prominent posterior superior cardiac border, lateral view, and your posterior displacement and the flipment of the left main bronchus. Now, what are the disease conditions that can cause your left atrial enlargement? You have the acquired heart disease, such as your moderate to severe mitral stenosis and your moderate to severe mitral regurgitation secondary to rheumatic heart disease, your left ventricular failure, and your left atrial myxoma. For the congenital, you have your moderate to large ventricular septal defect, VSD, or your moderate to large patent ductus arteriosus. How about the left ventricular enlargement? On PA view, you have the lateral and downward displacement of the cardiac apex. Then on lateral view, you have the posterior displacement of the posterior inferior border of the heart. And also take note of your Hoffmann-Ridler sign, which is measured 2 cm above the intersection of the diaphragm and the inferior vena cava. And there is a positivity if the posterior border extends more than 1.8 centimeter of the inferior vena cava. Okay, now what are the disease conditions that can cause left ventricular hypertrophy? These are the severe aortic stenosis wherein there is fusion of your cusp. You have your right coronary cusp, the left coronary cusp, your non-coronary cusp. Then you have your moderate to severe aortic regurgitation, moderate to severe mitral regurgitation in rheumatic heart disease, grade 2 hypertension, moderate to large patent ductus arteriosus, moderate to large ventricular septal defect, your AV canal type of defect, wherein you have primum ASD and the high type VSD plus a cleft mitral valve. The AV canal type was known before as your then you have your dilated cardiomyopathy. Now, the next slide shows you a typical ventricular enlargement wherein you have an enlargement of the right as well as your left ventricles. This slide shows you now the different chambers of the heart. On the upper figure on the left, you have your left atrium and your atrial appendage. On the upper left image is your location of the right atrium as emphasized with the green color. On your in the lower part slide on the left is your left ventricle highlighted with the red color, and also in the lower picture, on the right side, you have your right ventricle, representing the blue color. Okay. So the next few slides is just a slide showing you the third mogul sign, then also the arrow